have to say that I didn't prepare this slide for English presentation, but since we have many international attendees, so I will try to present it with English. And this is my case. So this is 12-lead EKG, and pay attention to this slide, and I'm going to ask each of you about your opinion in this EKG.
누가 먼저 하실래요? 이준영 선생님 뭘 둘이 먼저 이런 걸 했어요. 먼저 하세요.
Widespread tachycardia, and there's the concordance in prepository rate, and inner slope is slower than inner slope. I think this is widespread tachycardia, and there's positive wave reading to negative, and CMV1 very big pattern. So, and I think there's not obvious RS transition in precaudal rate, and there's no CMV1, there is no notching, and that's monophasic rate. So in conclusion, I think this is maybe RVOT origin.
Why do you believe it is BT? We need to list up the differential diagnosis: aberration, fixed bundle branch flaw, paced rhythm, excitation. Of course, the probability of the BT is the highest, but please show us what you see.
First, there is no concordance of precaudal rate that suggests great tachycardia, and seeing AVR and reading to the initial slope is slow, so also suggests tachycardia. And
do you see any atrial activity? Can you identify any atrial activity in this EKG?
Dissociation or something?
Can't find AV dissociation.
You cannot?
B1 한번 보세요. 마우스로 한번 짚어봐. B1. 없을까? 따라가 보세요. T웨이브 컨트롤가 좀 이상한 거 없어? 조금 더 가봐요. 그 옆에. 보기 좀 다르지 않아요?
You can see actually much better in AVR. Take a look at the AVR. Terminal QRS. Every other bit has indentation. Do you see it? Can you see it? Right?
Yeah.
Okay. So you can say there's another electrical activity adding on to that. The reason is that we are saying what? This is important. There's a part of a QRS where you cannot have any additional activation. When is that? When ventricle is refractory, correct? So you know cellular physiology, depolarization, repolarization. During the depolarization and then also absolute refractory period, repolarization, you cannot have any other wavefront. Therefore, you should see exactly the same SDT wave segment. But whenever you see change, there's additional wave other than ventricle working. Only can be atrium, right? So conclusion is there's a 2-to-1 maybe, atrial activity going on, and then your ventricular rate. In other words, I should say ventricular, but why the complex is driving the small notching 2-to-1. That's what you can say. So our exercise here is not make a right diagnosis. We want to exercise your brain so you can come up with, when you see ECG, differential diagnosis, okay? So if you start say, oh, this is a ventricular tachycardia, yes, probably correct. However, that is narrowing mind already focused into your brain say, oh, this is VT. In context of in context of patient, for if, let's say that you see this EKG in outpatient clinic. You've seen a patient come to history, and then present this EKG. You need to try to interpret this in context of patient clinical finding as well. So that helps you. However, keep note that sometimes rare differential diagnosis is important because you want to go step by step, not to miss anything. For example, nobody said the patient only has ventricular tachycardia. Could there be atrial fibrillation, flutter, different arrhythmia going on? So double tachycardia, for example. So you won't miss those things, okay? So always try to open your mind, look at it. So there's a 2-to-1 possible atrial activity relationship. That's why the complex tachycardia. I think it probably are correct. So you describe basically why the complex tachycardia with the lap bundle branch morphology pattern appears to be, but not quite lap bundle, but there. No, almost no transition, whether there's an R wave, a little bit in the V4, V5, V6. But in R wave, after that, what you see, V5, V6, you can see very nicely. Downstroke notching, you see that? That only happened VT, no other diagnosis. Second point is that you said the RVOT. Is there any other tachycardia can do this beside the RVOT? Because I assume you got S-wave lead 1 and AVL, that's why you said RVOT. But transition-wise, is a little bit late to be at RVOT, okay? RVOT transition would be P2, V3 typically, or can be early as a V1, V2, depending on heart shape and anatomy. So this is not RVOT, okay? So those things become more specific as you're coming down, narrowing down, okay? Try to exercise your brain much as you can during the training fellowship. Don't be afraid to speak wrong diagnosis. It's not, we are about discussing wrong diagnosis here. We are not trying to ask you, stress you. Relax and try to think, do the best we can. That's what we can say, ask you, okay? That way we share more. Sometimes some of the students throw a question that we never thought before. That's all about this one. So everybody has some different ideas. So we like to also know how you think, so we can share the thought process. Okay. Anybody else want to add any comment, please?
Because we are EP physicians, so we need to localize where this tachycardia coming from.
Good
So
morning.
I would like to listen to Dr. Huang, Dr. Kez, not Kez thoughts.
Frankly speaking, I thought this disease was ET applied originally from the RBOT.
But already
Yeah,
Dr.
already
Huang
Dr.
told
Huang.
that it is too late transition, right? If you want to bring this patient to the EP lab, you need to think about how you will approach for mapping and how will catheter, which catheter you will use. So
Actually, I think I tried to map the RBOT first, then if there is no only signal from the RBOT or behind the pulmonary valve and above the pulmonary valve, then try to that side, there was kind of there, and then that RBOT area.
can see negative complex centrifugal rate, so it coming from apical area and
apical LV apex is opposite side to the RV outflow tract, right?
That's right. But
That's the
it's
dilemma.
and you see it to 3 AP left, and it's coming downward direction and lead one negative. Uh,
So from newcomers, brain exercise. 했는데 패턴을 넣고 매핑 해보면 되는 거지, 그지? 뭘 고민을 해?
I think even though the transition, there's no transition in precordial leads. Anterior orbit OT is possible without transition. Or because there, I thought it might be TV annulus, but AVR is relative, so I think it's anterior or proceptal RVOT.
I have curious, the 정세영 선생.
Yeah.
Is this the standard 12 lead ECG or the treadmill? Standard 12 lead.
Okay.
So if you, I hope, I don't know whether you can change your mind or not, but take a look at the lead one. What do you think? Is this a truly QS or there's a RS?
They're small R.
Yes. First 40 milliseconds isoelectric, and then second 40 milliseconds R, and then you got sharp S, and then end the terminal there's a notch. So that's the anti-QRS complex this patient. Okay. And then AVL is also negative, and ADR. So look at the total ECG where your ECG can manifest like this. And then also transition is relatively later. So, and then we just talked about right bundle branch block. By probability, you say, oh, this could be right side. Because typically right ventricle would give you left bundle VT will give you right bundle, right? And the fact is that the notching is in the septum, and somewhere in the middle of QRS complex. That means vector comes around and then suddenly change almost 90 degree. So there is a certain parameter here that you need to start thinking that way. Second important thing is that if you have a left ventricular DT, let's say that the QRS should be wider than right ventricular DT, simply because the critical mass of the right ventricle much smaller than left ventricle. Okay, unless this VT involve conduction system, it's Purkinje, so forth. But it's not. Okay, it's not a typical. So now that change your mind after my comment? Where is it coming from? Lead one is a biphasic. It can be a left ventricular tachycardia, left outflow tract can have such a deep S-way biphasic. Very unlikely. No. So I think this is going to be like what I said. Right ventricular outflow tract front part, anterior wall, tend to have a significant notching like the B5, B4, B6, because simply there is no conduction around the RV anterior wall. Septum posterior there is. Therefore, your conduction can be depending on the vector. They can switch quite big. So notching is important, whether ascending or descending portion of QRS complex. And second is that the transition may be a little late, but there's an R wave. Okay, so you can see V3, V4, V5, V6. So probably anterior, but RV or outflow tract anterior septal, probably not a septal, probably a little more anterior, a little bit lower, not the high. That's why you give a lead one is biphasic like that. Okay.
Even though the Dr. Lee told the base that the B3-4 is negative concordance, so it is apical located, but that rule is only can be reflect to the LV.
Right.
RV is on the top of a left ventricle, is almost anterior to the precordial lead. So you cannot apply the V3-4-5 deflection to the RV origin ventricle. So I agree with Dr. Huang, so I would like to put the catheter in RBOT and map all the, along the infundibulum area and anterior wall. But it, how do you think? It doesn't seem to be epicardial.
No, it's not epicardial.
Because
This is-
QRS is relatively.
This is typically Dr. Bach say RV infundibular VT. RV infundibular VT, you folks go study today, RV infundibular VT title. There's several paper published lately. Read the last author named Yamada, okay, Professor Yamada from University Alabama. So I went to read that paper he published in Circulation about 2 years ago. He differentiated between right bundle, left bundle morphology, infundibular VT. Okay, infundibulum is a very important subject in the right ventricle. First of all, we have a very strong interest in Brugada syndrome. VT, mostly ablated, actually fragment signals come epicardial infundibular region, the transition between outflow and inflow. That has the histology of that area, musculature layers, so forth. And infundibular VT tended to be very complex. Mapping is difficult, ablation difficult, because the infundibulum become quite thick by the time outflow tract migrates to the ventricle. Therefore, mapping can be extensive and also require a lot of ablation that determine what type of tool you're going to use to ablate this and so forth. So important to know this scientific information before you prepare for the patient. You're not going to ablate this, for example, with a standard ablation. You may have to do irrigation, number one. Number two, you may have to put a 2 patch instead of 1 ground patch, and then you may have to have normal cell line. Sometimes, in cases of a bipolar ablation from epiendocardial ablation, there's a case report. So it is an implication is a little bit more complex than you think, but it's just fun. We're not talking about ablation, sorry. So it is something that you need to think about it, okay? So sometimes you can tell you a lot of story. So that's why it's so much fun about the EP, yeah, okay? You need to have a lot of deductive thinking, first year fellows. Welcome to the club. So any other comment, please do.
I have a question. If you say this is from anterior arterial infundibulum, you said that it was from, not from upper.
No.
But lower. How can you differentiate from the two?
Upper and lower.
Yeah.
Okay. Upper, first of all, as you said, our way of transition should be typical, V2, V3, except the notching will be anterior ascending notching, QRS, like what you see right there, okay? Now, notching from anterior RV tended to be an ascending portion of a QRS complex during the VT. Left side, descending portion. Except the left side will be narrow complex because it comes from septal portion, invading your conductors are very quick. And the right side will be wider QRS complex because there's no conduction system, and then notching which is slurred. That explain to you? Make sense? Good.
The most common site of RV outflow tract VT is just below the pulmonic valve,
Right.
But the infundibulum VT coming from little lower, there's a septomarginal thick bundle and septoparietal
Right.
bundle at junction. Some patients is very thick. So that's why the Dr. Wang told there, it is sometimes very difficult.
And the other thing that Doc commented is important because this bundle's conductions are somewhat different than regular muscle. When you ablate one form, they change to different form, exit, because you are mapping on the exit side. We cannot map true focus from endocardium sometimes so thick. So you're guessing where it might be, and then you ablate. That's when it has happened to be. Preface a conduction point, and then exit to the other side. And then you have to go chase that guy. It is a very fun tachycardia ablate, but then you need to start thinking how you address this issue. Okay, very good. So tell us the rest of the story.
Yeah.
Now Drew's coming.
Thanks for sharing your deep insight. And this patient, this patient came to the clinic for with strip complaint of palpitation for 1 year ago, and he had a history of hypertension and dyslipidemia with medication of micardis 20 milligram and Librelo 4 milligram. And after the EKG I presented in the first slide, the patient tried the Indeno 16 milligram, and the EKG was converted to this slide.
Okay, so
There-
what do you see?
uh,
Every EKG you have to read. You can't just go pass through.
yeah. In my opinion,
Mhm.
in my opinion, this is the EKG with the PVC, and the morphology is similar to the V-tag EKG we saw earlier. So, yeah, I guess this PVC is related to the ventricular tachycardia.
Okay, but let me ask you this question. Is a PVC coupling with the preceding QRS complex, does it matter to you? Is there any significance to it? You think?
I think the interval from the former sinus rhythm QRS to the ventricular QRS is about 0.5 millisecond, and
So when you
Mm.
see, okay, well, we are asking two things. When you see
Yeah.
PVC,
yeah,
you can have a automaticity focal trigger,
yeah,
okay? And then the automaticity can be truly parasystolic, may not be, okay?
yeah.
So if you look at this ECG, what do you see in V4, V5, V6? What is this guy abnormal, normal, or think unusual, let's put it that way. What do you see? Sinus rhythm, QRS is normal, PR is normal, then T wave. After T wave, what you see? What is that second wave? It's called the U wave.
오늘이요?
Yeah.
Before. lateral frequency.
Yes, patient got huge U wave, right? And then look at where the T wave is PVC falling. Right at the U wave. You see it? So you need to start thinking mechanism of tachycardia now. Now you got a 43-year-old guy, hypertensive, suddenly presented with 1 year after palpitation. He never had this before. And then you're having PVC coupling is on the U wave, having tachycardia. Is there something meaning to you? That's what we are asking. So, yeah, U wave mechanism, is a lot of time people say is a benign venous issue, but then sometimes may not be. Some cases like this, you need to start thinking why the PVC happen in U wave and it has a monomer VT. So then muscle mechanism is VT, is on TT, or this is a trigger in this reentry. It's all possible because you got short coupling interval, even though it's not a T wave, but it's on the U wave. So it is something that you start scratching your head. There may be something unusual going on there. Okay.
죄송합니다. 미니 뭐라 그래?
Huh?
UAV의 뜻.
Oh no, I'm talking because the coupling of a PVC has to happen to be falling right at the U wave. So I want to know is the potential implication, clinical implication of this, which is just isolated PVC. You got one bit on, unfortunately. I cannot tell whether this is a parasystole or not, but you got PVC couple falling right at the U wave. So do you have any other ECG in this patient? Maybe you can show to us.
I have the telemetry.
Yes. Okay, that's
This is trans. Yeah.
normal.
What?
Yeah.
What? LBH only.
Yes.
What?
That's important though. What you said up there?
Wow.
No, just before. What Echo said. Pseudo normalization of the LV feeling pattern.
Diastolic.
Yeah,
Diastolic heart failure.
dysfunction.
Yes.
Yeah. And with the history of hypertension, the
Right.
patient has the eccentric LV hypertrophy
Right.
with degenerative change of aortic valve.
Correct. So basically, patient has a hypertensive heart disease
Yeah.
manifestation, young age.
Yeah.
43 is rather younger than you expect to be normal, unless patient has malignant hypertension or something like that. We don't know the rest of the story. Then you go to the telemetry strip. Okay.
This is
Yeah,
the-
there you go.
you
What do you think? The PVC that trigger, they look exactly like a VT or they're different? That's I want to know now. First is a PVC, okay?
Yeah.
Second is tachycardia. Tell me if they are same, similar, or different. What do you say?
It's different.
Different. They're not same.
Which one is V1?
I think this is a sort of a telemetry, so I don't know whether which one to be, but
No, our telemetry shows a V1 and V5.
mhm.
So which one is V1?
The bottom.
No, that's got to be
Bottom
wrong.
V1, yeah?
Yeah, no, I think it's wrong. That doesn't matter, but you can see several lead. First complex is a PVC. Second one left onward is tachycardia, right? So first of all, I want you to look at the RR interval between first and second bit. A little bit longer than BT, right? First is a PVC, second is a sort of a VT starting, initiating, 1, 2, 3, then settle down. You said? And QRS morphology is not same, those three. Am I misleading you or am I telling you sort of a imaginary theory here? What is that? It is different. Okay?
Yeah.
So what is the therefore mechanism is what? This VT. Cannot be automaticity. Okay? Because if it's automaticity, your rate would be same. Sometimes you can have a fast automaticity that gradually slow down, terminate. It's called exit block pattern. That's automaticity. This is the focal trigger, probably some sort of VNT mechanism that UAV has to do with that. This involves probably repolation abnormality. Maybe it has to do phase 2 re-entry and so on, but only can speculate based on that. So your presentation really good. Basically, what you have to do, look carefully when you next time look at the unmeasured RR intervals and so forth, morphology, and that will give you more interesting, different ideas. Okay. Obviously, you're going to take this patient to the EP lab. You're going to demonstrate all that, but the reentry or this focal, so on. But we are just looking at the ECG, surface ECG. Okay.
Dr. John.
Yeah.
In your history taking, there's two things you need to add. Number one, does this patient has a history of syncope?
No, he just had the palpitation and the dizziness, but
No syncope.
yeah.
And the family history of sudden cardiac death.
No, he didn't have any real
So
history.
that is mandatory for the patient with arrhythmia, any kind of arrhythmia. So there is a report from the Schmidt. Even though there most of frequent PVC or idiopathic VT is benign,
Yeah.
not beta, but the short coupling interval PVC
Yeah.
and the history of syncope, family history, those are high risk of sudden cardiac death.
In this patient, you can see even telemetry U wave. This is not normal. Get the lead to second lead. Lead 2. You see U wave coming in, flipped around. So U wave always follow T wave. Okay. When the U wave starts opposite down to T wave, that's a pathologic. Okay. So there's a rule of EKG you read in textbook. QRS follow T wave, follow QRS axis in general, also does a U wave. When U wave start flipping, alternation, that's a very much abnormal repolarization. Okay, important concept to read. So when you read the EKG, try to look at it. Maybe this patient U wave flips before initial tachycardia. So there's some sort of a physiologic, some other alteration going on, electrolytes, whatever it might be. You need to find that answer. That's you clinically assess the patient. Okay. Anything else? Yes, please.
In the lead V1.
I don't know the V1. What lead that is?
Yeah, the V1
Oh.
positive.
I
Why does it change from?
I can't tell whether that's a true V1. That's because it's a telemetry. But it doesn't look like a V1. completely different BP looking at this, right? So that's why I'm curious, but I'm just looking at that difference morphology only the way it is. Could it be right? Could it be wrong? I have no idea.
Multiplex it.
It's possible, but then
Do you guess?
But the during sinus rhythm, purest complex is not anymore. So I agree with the V1 position is not real.
okay. Great, good case. So we discussed a very interesting case today. Okay, let's go. Rest. Yes, please, go ahead.
Travel ECG, please. Give us PVC opening. Okay, the next one, please. Next one. After PVC, the QRS complex was preceded
You mean-
RR interval short.
Yeah, I saw the same thing. The narrow QRS RR interval looks shorter than other RR interval, but
Right.
is it? I'm not sure. It may be the visual hallucination
What?
before measuring it.
That's not yet. That's gonna be my first time yours hallucinations. But
해봐요 한번.
okay,
해봐요.
is that
Escape
What-
누르고
yeah?
아니면 스크린에서 캘리퍼도 재는 거. 그냥 이걸로 재봐.
So first thing you need to do. Okay.
시간 없이.
Yeah. First thing you need to do, measure the PP interval. Two couple.
Sometimes it's hallucination.
Yes.
Hi.
About the same? Or a little shorter.
Almost same.
Almost
Almost
same.
Yeah, that's hallucination.
So what, what he's asking? There's a mechanism of what we call sinus arrhythmia, okay? When the complete heart block, for example, you will have a RR interval change because of a PVC couple or either PP interval coupled within the heart block. PP interval can be shorter. So we know as a, phasic sort of arrhythmia.
Ventricular
Yes,
sinus
right. So, but certainly if you have a complete interpolated PP interval, won't matter. You know what's interpolation mean? You guys don't know about interpolation, go read it today. Because I'm not going to explain everything. I want you to study, okay?
But generally, the ventricular phasic sinus arrhythmia, PVC, make a different radiator pressure, change the sinus rhythm, the PP interval. Generally, it increases the vagal transient
Right.
in the prolonged.
It's a physiologic phenomenon, not clinically meaningful, okay? But when you have a sinus arrhythmia pathologic, they don't follow the rule. So there is a three types of sinus arrhythmia. Physiologic, the youngest people breathe in and out, you see in the babies and all that, right? And second one is the talking. Third one is a pathological one, okay? So you folks have today three topics to read about it. One, sinus arrhythmia type. Number two, ventricular phasic PA mechanism. And then infundibular anatomy, BP. Every time we comes up, foreign fellow is going to be assigned a certain topic to study. We're not going to check on you, but it is important that you master this. Okay, let's go.